Hello everyone, this is Shad Reis from SIF 2022. With me is Dr. Megan Coylewright. She is from the Erlanger Heart and Lung Institute, and she has been very present on the podium for the majority of the first day of SIF 2022. Megan, always a pleasure to talk to you.
Great to see you.
Thank you. So we talked before going on record that there is a new technology about intra-arterial shunting, but has a new indication or a new trial for heart failure. Tell us more about it.
We are always looking for solutions for heart failure. Some of our successes have led us to where we are in the heart failure epidemic. We've been saving people from heart attacks, and we've been treating their valve disease, and now we have a large group of patients who continue to have heart failure and are plagued by congestion, where they're needing large doses of diuretics or they're in and out of the hospital. So we're always looking for ways that we can improve that. And recently we've had increases in the medication options, for example, that we can offer. But some patients don't want to be on that many medicines, or it's not improving their congestion to where their quality of life is where they'd like it to be. So there is a new device that is out there to help address heart failure. And we call the general idea of this intra-atrial shunts. And the idea is that congestion comes from high left atrial pressures, independent of mitral disease, just that the left atrium is overloaded because of LV dysfunction, whether it be diastolic or systolic heart failure. So if we could reduce the LA pressure without overloading the right side, then we could potentially improve patient symptoms. So the idea of intra-atrial shunts is you put a little hole in the septum to allow pressure to come out of the LA to the right side, but not too much volume. So there are 3 devices that are out there right now that are in trials. So I can tell you a little bit more about that.
Tell me, so how you can decompress LA without moving volume? Because we know that sometimes we do septostomy for patients with advanced end-stage pulmonary hypertension.
Right.
But it's still volume issue or concerns. But you're telling me just decompression. How would that happen?
It's a great example to bring up the treatment of opening up the septum for pulmonary hypertension. Then, of course, you're having some unloading of the right side, right to left shunting. So in this case, we're thinking about unloading the left side. And the corollary of that would be an atrial septal defect. So you might say, well, we close those, but we don't if they're small. If they're small, they don't cause any problem to the right side. We usually think about less than a centimeter as one that people could live with for their entire life. So it's really important that we understand what size would be appropriate to have this balance of unloading pressure without having too much volume. And so we have a couple of trials to help guide us. So one of the devices, Corvia, recently published their data in Lancet and presented it at one of our first interventional heart failure meetings that happened in New York, where we're looking at all sorts of devices that can improve heart failure. And that study was neutral. It did show some benefit in subgroups, although we don't look at that if the overall trial is neutral. But the trial was able to recruit 60% women, and women did benefit from the intra-atrial shunt device compared to men. But we look at the overall study, it was neutral, and some of it is making sure that we identify which patients would be most appropriate. And it seemed that patients that had RV dysfunction of some kind or very high pulmonary pressures with exercise were less likely to benefit. So there's another trial ongoing with a different device called V-Wave, and their early roll-in data did show benefit for quality of life in heart failure symptoms. And then we have a third study that's coming that I'm the national PI for, and that's a device that's made by Oclatech. It's called the Atrial Flow Regulator. One of the distinctions with this device is that it comes in multiple sizes. So we really have an opportunity to learn where's that sweet spot for unloading the left atrium
without overloading the right atrium.
Exactly.
So is this for HFrEF and HFpEF?
That's a really important question. We've struggled with identifying with this really heterogeneous group of people which therapies are best. Sometimes we get excited, we have medicines now finally for HFpEF. In this initial study that I just talked about by Corvia that was published in Lancet, that was for HFpEF only. The V-Wave study is looking at both, and the Oclatech study will look at both. So we think that there is probably an opportunity to further identify which patients are most likely to benefit. But we're specifically looking for patients that have heart failure and have evidence of congestion and impact on their quality of life.
So let's a little bit focus on the recruit, and I don't want to indulge into too much of the design of the trial.
Yeah.
Are they stage C heart failure or stage D heart failure, and this is the last resort? Or you want to catch these patients a little bit earlier to prevent them from congestion?
That's a really smart question, and it's one that we struggle with in so many areas of structural interventional cardiology. It makes me really think about all the work we're doing in tricuspid regurgitation, for example. When do we reach patients?
When?
And in this case, I would say it's a little bit more further down the line. We really want to make sure they're optimized on all medical therapies first, and I think we all buy into that very quickly. One of the things I'm interested in is it might not be in patients' preferences to be on all of the medical therapy before they go on a device. A device might actually improve their quality of life because of their ability to come off of medications.
Correct.
That's not how we're studying it right now, though.
So because as a TAVR, for example, we started with the sickest patient, we say it's good, let's go downgrade to the high risk, intermediate. So it looks like you're almost getting the same
Consistent theme, I think, throughout interventional trials.
Yes,
Yeah.
absolutely. So also, I want to make a segue towards the paper that was in JACC about lack of female representation as PI in clinical trials.
Right.
Which is, I think, is a big deal. It's been there going on for a while, but now it's getting attention. Why just now?
Well, I think we're at a time period where there feels like there's an opportunity to make a move on this important issue. So when we think about running clinical trials, we want to make sure that at the end of the day, whatever it is that we find out is applicable to all of our patients.
Absolutely.
We want to make sure that the device is tested in the patients that are in front of us in clinic. And what we've found over the past is that the majority of our cardiovascular trials have been primarily white men. So we haven't had the knowledge that we need to understand whether it's more effective, for example, in diverse patient populations. A recent paper in EP showed that early ablation versus medical therapy was effective in racial and ethnic minorities, while the primary trial did not show that same benefit. We don't want to miss those important messages for our patients.
Absolutely.
And what we found from prior literature is that the more diverse your national PIs are and your steering committee, the more diverse the patients are that are included in the trials.
Interesting.
So that we have the best science possible, we want to make sure that the leadership looks like the patients in front of us. So the recent JACC article that was led by Harriet Van Spal demonstrated that we really have had disparities in clinical trial leadership. And so my role as national PI for this intra-atrial shunt device is important to me because I want to make sure we recruit site PIs that are diverse all throughout the country.
To have the balanced population in your trial.
Exactly. So that's work that we're doing right now to try to reach out to those investigators or people who maybe haven't been involved in clinical research before to invite them to be a part of this study.
Starting upstream.
Yeah, and get involved.
Thank you so much, Megan, for your time. Really phenomenal information about heart failure therapy, exciting technology, as well as being a leader, a woman leader in cardiology, especially in the research. Please watch this video and other videos on SIF YouTube channel. This is Shad Reis from SIF 2022. Megan, thanks again.
Thank you so much.